All right, class. Today we're talking about pain management interventions. This is one of the most important and testable topics you'll see, not just for exams, but in real patient care. Achieving optimal pain relief is best viewed on a continuum. Our main goal is always to provide effective and safe analgesia. That means pain control that's strong enough to let the patient move, breathe, and heal, but safe enough to avoid complications. The quality of pain control should always be addressed whenever patient care is passed from one clinician to another, whether that's during change of shift or transfer from one unit to another. Pain relief isn't just a one-person job. It's the responsibility of every member of the healthcare team. Optimal pain relief starts with titration, adjusting the dose of the analgesic until the patient reaches their comfort function goal. That's followed by continued assessment, prompt medication administration, and non-pharmacologic interventions to help patients meet their functional goals with relative ease. Now, sometimes it's not possible to reach a patient's pain goal while they're still in a short-term area like the PACU or the emergency department. But that goal gives direction for ongoing care. When we give report or transfer a patient, it's essential to include their comfort function goal, how close they are to meeting it, what's already been done, meaning the medications given, the doses, and any non-pharmacologic methods, and how well the patient has tolerated those medications. There's a growing interest in linking pain management to functional goals, not just pain scores. For example, one tool called the Clinically Aligned Pain Assessment, or CAPA, looks at comfort, function, pain control, and sleep. Remember, pain management should help recovery, not interfere with it. Now let's talk about pharmacologic management, specifically multimodal analgesia. Pain is complex and rarely managed well with just one drug. Multimodal pain management intentionally combines medications that work in different ways, plus non-drug interventions. The benefit? You can use lower doses of each drug, get better pain relief, and reduce side effects. For example, pairing acetaminophen with an NSAID and a low-dose opioid can produce stronger pain control with fewer complications than any single medication alone. Let's move into routes of administration. The oral route is preferred whenever possible. It's best tolerated, easiest to give, and most cost-effective. But if the patient can't swallow, is NPO, or nauseated, we use other routes. In the immediate postoperative period, the IV route is typically used first, and we switch to oral as soon as it's tolerated. The rectal route can be helpful when oral or IV routes aren't options, like in end-of-life or palliative care, but absorption can be unpredictable. Avoid rectal administration in patients who are neutropenic, thrombocytopenic, or have rectal issues like abscesses or diarrhea. The topical route is used for both acute and chronic pain. For example, diclofenac gel or patch can be applied directly over painful joints. Lidocaine cream or a 5% patch is great for localized neuropathic pain like postherpetic neuralgia. Remember, topical acts locally, while transdermal must be absorbed systemically. For advanced pain control, we also use neuraxial analgesia, meaning epidural or spinal delivery. Medication is administered into the epidural or subarachnoid space, either as a single dose or through a catheter for continuous or patient-controlled epidural analgesia, also known as PCEA. The most common opioids given this way are morphine, fentanyl, and hydromorphone, often mixed with a local anesthetic like bupivacaine or ropivacaine to enhance pain relief and lower the opioid requirement. Another option is a continuous peripheral nerve block, also called a perineural block. Here, a catheter delivers local anesthetic, often ropivacaine or bupivacaine, continuously near the nerve supplying the painful area. This allows pain relief without full motor loss, so the patient can still move and walk safely. Now, let's move into dosing regimens. Optimal pain management requires both patient education and frequent reassessment. When pain is continuous, that means present for 12 hours or more per day, we use around-the-clock, or ATC dosing, to maintain stable medication levels. For intermittent pain, like before procedures, or for sudden pain spikes, we use PRN dosing or breakthrough pain, often abbreviated as BTP. One of the most effective techniques for pain control is patient-controlled analgesia, or PCA. PCA allows the patient to self-administer a preset dose of pain medication using a programmed pump. This is commonly used for postoperative pain or other acute pain situations. The pump is programmed with a set dose, a lockout interval, and sometimes a basal rate, a continuous infusion. A basal rate may be used for patients who are opioid tolerant, but it's avoided in opioid-naive patients because of the risk of oversedation and respiratory depression. The key idea behind PCA is this: only the patient should press the button. Never family, never staff. That's called PCA by proxy, and it's dangerous. Quality and safety nursing alert. Family and visitors should never push the PCA button for the patient. If they're concerned about pain, they should alert the nurse instead. For patients who can't physically press the button, like those with limited mobility, there's an option called authorized agent-controlled analgesia, where a nurse or trained caregiver administers the doses following strict guidelines. Let's talk about analgesic medications. They fall into three main groups: non-opioid agents, opioid agents, and co-analgesics, also called adjuvant agents. We'll start with non-opioids, acetaminophen and NSAIDs. These are first line for mild to moderate pain and can be used with opioids for multimodal therapy. Because they work differently, you can safely give both together. Acetaminophen is versatile. It can be given orally, rectally, or intravenously. IV acetaminophen is great for post-op pain, though its opioid-sparing benefits vary between studies. The maximum safe adult dose is 4 grams per day, though many institutions cap it at 3 grams to reduce liver risk. Always avoid acetaminophen with alcohol or warfarin. Alcohol increases liver toxicity, and warfarin levels can rise, increasing bleeding risk. NSAIDs like ibuprofen, naproxen, and ketorolac are highly effective for inflammatory pain, but come with GI, cardiac, and renal risks. The main problem is gastric ulceration, caused by blocking COX-1 and reducing protective prostaglandins. Risk is highest in older adults and those with a history of ulcers or cardiovascular disease. To reduce this risk, choose a COX-2 selective NSAID like celecoxib, or pair a traditional NSA with a proton pump inhibitor. Remember, always use the lowest effective dose for the shortest time. IV ketorolac and ibuprofen can provide excellent short-term pain relief and reduce opioid requirements, but should be used cautiously in patients with kidney problems or bleeding risks. NSAIDs can also affect renal function, so ensure adequate hydration and monitor kidney labs closely. Now let's move into opioid analgesic agents. And just a quick note, the term narcotic is outdated and inaccurate in the clinical setting. When we're talking about pain relief, we use the term opioid analgesic. Opioids are divided into two main groups: mu agonists, also known as morphine-like opioids, and agonist antagonists like buprenorphine and nalbuphine. Mu agonists, including morphine, hydromorphone, fentanyl, oxycodone, and methadone, work by binding to mu receptors in the brain and spinal cord to block pain transmission. When opioids bind to these receptors, they produce analgesia, but can also cause side effects like sedation, constipation, nausea, and respiratory depression. Agonist antagonists, like nalbuphine, can trigger withdrawal in patients taking mu agonists, so they should be avoided in those on long-term opioids. Antagonists like naloxone and naltrexone bind to opioid receptors but don't produce pain relief. They're used to reverse opioid effects in emergencies or as part of addiction treatment. Selecting an opioid requires an individualized plan, considering pain intensity, age, other conditions, current medications, and patient history. Opioid therapy always involves titration, using the smallest dose that achieves adequate relief with minimal side effects. For chronic pain, doses may increase gradually. For acute pain, doses are reduced and discontinued as healing progresses. When switching between opioids, we use equianalgesic dose charts. These show doses that provide roughly equal pain relief. For example, 30 milligrams of oral morphine equals about 10 milligrams IV, and 100 micrograms of IV fentanyl equals about 4 milligrams of IV morphine. Always remember, these are guidelines. Doses must be titrated to the individual. Now let's talk about dependence, tolerance, and substance use disorder. Physical dependence is a normal, expected response to ongoing opioid therapy. If you stop suddenly, the patient may experience withdrawal. That's why we taper slowly. Tolerance is also normal. Over time, the same dose may provide less effect, so adjustments are sometimes needed. Substance use disorder, or SUD, is different. It involves compulsive, harmful use of opioids for non-medical reasons. It's not the same as dependence or tolerance, though they can overlap. Pseudo-addiction is another important concept. It looks like addiction, but the real issue is inadequate pain control. Once pain is managed properly, those behaviors resolve. Opioid-induced hyperalgesia is the opposite problem. Patients become more sensitive to pain with higher opioid doses. It's rare, but if pain worsens as the dose increases, this should be considered. Now let's cover the main opioids you'll see. Morphine is the gold standard. It's hydrophilic, meaning slower onset but longer duration. It has two key metabolites, M3G, which can cause neurotoxicity, and M6G, which contributes to pain relief. Fentanyl is lipophilic, rapid onset, short duration. It's ideal for quick relief or short procedures. It's also available as a transdermal patch for chronic pain. But remember, it takes about 12 to 18 hours to take effect and remains in the system for at least 16 hours after removal. Heat can increase absorption and cause overdose. Never use the patch for acute pain. Hydromorphone acts faster than morphine and has a shorter duration. It's often used in IV PCA and available in extended-release oral forms. Oxycodone is oral only. It can be short-acting or modified release and is often combined with acetaminophen, but be careful not to exceed the acetaminophen limit. Hydrocodone is also combined with acetaminophen or ibuprofen and is appropriate only for mild to moderate pain. Methadone is unique. It's a mu agonist and NMDA antagonist, which makes it useful for neuropathic pain and opioid use disorder. It has a long, variable half-life, which can cause accumulation and sedation, so dosing requires expertise. It can also prolong the QT interval on ECG, so monitor closely. Tramadol and tapentadol are dual mechanism agents. They weakly bind to mu receptors and block reuptake of norepinephrine, and for tramadol, serotonin as well. Tapentadol has fewer side effects and no active metabolites. Watch for serotonin syndrome when tramadol is combined with SSRIs. Now, opioids to avoid. Codeine must be metabolized to morphine to work. About 10% of people can't metabolize it at all, so it's ineffective. Others convert it too rapidly, which can cause overdose, especially in children. Meperidine is rarely used because its metabolite, normeperidine, can cause seizures and delirium. It's only used in very small doses to treat post-anesthesia shivering. Next, adverse effects. Common ones include constipation, nausea, vomiting, itching, low blood pressure, and sedation. The most serious, and the one we always watch for, is respiratory depression. Morphine can lower blood pressure through vasodilation, especially in dehydrated patients or those on antihypertensives. Constipation is almost universal with opioid use. Tolerance doesn't develop to this side effect, so always start a stool softener plus a mild stimulant laxative as prevention. For nausea and vomiting, treat with antiemetics as needed and use multimodal pain management to limit opioids. Itching isn't an allergy. It's a side effect. Antihistamines can help, but use caution with sedating ones like diphenhydramine. Sometimes just lowering the opioid dose or switching opioids solves the problem. Quality and safety nursing alert. Opioid-induced respiratory depression is dose-related and almost always preceded by increasing sedation. Prevention starts with using the lowest effective dose, titrating carefully, and monitoring both sedation and respiratory status. Sedation always comes before respiratory depression, so we use the Passero sedation scale to catch it early. Here's how it works. S, the patient is asleep but easy to arouse. That's acceptable, no action needed. 1, awake and alert. Acceptable. 2, slightly drowsy but easily aroused. Still acceptable. 3, frequently drowsy, drifts off during conversation. That's unacceptable. You need to monitor closely, decrease the opioid dose by 25 to 50%, or contact the provider for new orders. Ask the patient to take deep breaths every 15 to 30 minutes. 4, somnolent, minimal or no response to stimulation. That's an emergency. Stop the opioid immediately. Call for help, consider giving naloxone, and stay with the patient to support breathing. Naloxone should always be titrated slowly. Mix 0.4 milligrams in 10 milliliters of normal saline and give 0.5 milliliters at a time every 2 minutes until the patient responds. Too much too fast can cause severe pain, hypertension, or cardiac complications. Patients at greatest risk for respiratory depression include older adults, those with obesity, sleep apnea, or lung disease. Watch especially closely during the first 24 hours after surgery. When you assess breathing, don't just count the rate. Look for depth, regularity, and chest movement. Listen for snoring, which signals airway obstruction. All right, class. That's the full foundation of pharmacologic and opioid pain management. If you remember nothing else, remember this. Effective pain control is about balance. Enough medication to restore comfort and function, never so much that safety is compromised.